Okay, good morning. We're going to try and start on time because as you see, we've got a pretty packed agenda. It's wonderful to see so many people here and people from all different professions, backgrounds, who clearly have an interest in pharmacogenetics and trying to progress that, understanding a little bit about what we're doing as part of the network of excellence, but also hoping that there will be emerging from today an opportunity for us to work together, explore new projects, new networking. And so today we want to sort of highlight some of the stuff that we've been doing, but also to have a little bit of a projection to the future to think about what's doing. And there are lots of people here from the Northwest who are part of the team. So if you're from the Northwest, you're just a part of the sort of Network of Excellence, GMSA, just put your hands up so people know, so that people can look around and see. And if you've got questions about any of the bits of the program and you can't nab me, then there are lots of people that have got lots of information and be very happy to answer your questions. So you can see the housekeeping bits and bobs on the slide. There's Wi-Fi, there's no planned fire alarm or anything like that today. We've got some different rooms for breakout sessions, which will direct you to, you've chosen which workshops for a little bit later. So we've got a couple of different rooms, but there's also a room on the top floor so that if you wanted just a bit of time where you wanted a meeting with someone or just a little bit of space or an opportunity just to have a chat and a little bit of downtime, obviously you can just ask one of the team and we can direct you to that and you can use that space as you wish. Okay, so we wanted to start off today where I'd like to introduce my colleague Mark Dronsfield. Mark is one of our patient representatives, and one of the things that we've done as part of the whole program and is appropriately increasing the importance in not just research but in delivery of clinical services. It's right at the beginning, getting the user, the patient, the members of the public to sort of say, well, this is what we think is important, this is what we want the service to look like, this is why we think that we should make these changes, etc. So I'm just going to give the floor over to Mark for a few minutes just to talk about his perspective, if that's okay.
Just a little story about my early inspiration, yeah. So whilst working at the Sanger Centre back in, I think it was 76, I was setting up some instruments, and people who know the Sanger Centre knows that there's plenty of instruments down there for doing sequencing. So I'm a sequencing person. I think I was born a sequencing person. So sat in this room on my own, first thing, I think it's about 8:30 in the morning, yeah, I had a tap on my shoulder. I turned round and there was an old guy there, dressed in tweeds. I looked around and it was Fred Sanger. And he gave me my inspiration just in that week. So we had a full week together because he asked, can I come tomorrow? Next day, can I come tomorrow? So it was incredible. So I think I've been inspired by that for the last 35 years. And I think if he was here, he'd be proud of what is happening with things like the progress study. And so with that in mind, I take it through everything, well, not everything, but most everything that I do, just taking that inspiration. Unfortunately now he's no longer with us, but his journals are at the Wellcome Trust, and I would say if you've got time to go to the Wellcome Trust, I would go and have a look at those journals. I think I might actually be in some of them, maybe. So inspired by the progress study, I've been taking the animation regarding the study to my friends. Those friends, some of them are GPs, some of them are nurses, some of them are pharmacists. And the feedback I've got from them is, this is great, you know, you've got to make this work. You know, I think if this team can't make it work, I don't think anyone can make it work. Yeah, so, you know, keeping my fingers crossed for that to be the case. So at this point, I've been to like kind of 3 different GPs, and all have given like kind of incredible feedback about working with the progress study and the databases that they've got already, like EMIS. You know, it works with that. You know, so that is like kind of the early thing with just 3 GPs. You know, so I'm hoping that this is just going to progress. Yeah, and so that is still my inspiration.
Thank you very much, Mark. I think you've set the scene very nicely for what we're going to do now is just give a little bit of a background, just a little bit of a brief update. Some of you in the audience will be very familiar around the whole program of work. For some of you, it will be a little bit new. What we've tried to do today is to pick out some areas which some of you will have attended the meeting earlier in the year in March in Liverpool at the Spire, where we set out the program of work. And so what we'd like to do is tell you a little bit about what's happened since then, but also exploring some new areas that we haven't given much airtime to before, thinking a little bit about if there is a future network of excellence, what are the areas that we might want to take through, what are the new areas we might want to focus on, what are the new challenges. And so that's one of the things that we'll want to do. We're also to say that we're hoping to have our next event, and we'll provide details to all the attendees over the next little bit. Next spring, there'll be an event in the northeast, possibly in Newcastle. We're just looking at venues, etc. But we'll confirm dates. But one of the things to emerge from today is thinking about what things haven't we talked about today that you would have thought, oh, we should be thinking about that. That's an important area. So if there are topics that you feel that we haven't given enough airtime to, or any airtime to, please do flag those, and we'd be really keen to concentrate on those at our next meeting, which Emma Groves and the team up in the northeast are helping us to organise. And so let me just see if I can get the slides to move on. Or can you just move it on for me to the next one? Perfect. And on to the next one. Great. Thank you very much. So that's just the programme for today. You'll see that around and about. You see it's quite a mixed programme, particularly in the workshops and the afternoon sessions. We want this to be very interactive. We want to hear your views and your opinions. We know that there are lots of different ways to deliver pharmacogenetics. There are lots of moving parts, or lots of people involved from different perspectives, and we need to understand that what we're doing isn't the only way. It's one way. It's a way that we feel that we can generate some evidence to try to get pharmacogenetics adopted, but there are lots of different aspects to this, and that's something that we need to realise, that we can't do everything, but we've got to prioritise the areas that we feel that we can make the most difference in. So the network is based around 11 work packages. You'll see that the numbers look a little bit odd on my slide because I've omitted work packages 1 and 2 and 5, because John's going to focus after this with an update on progress and some of the data around that. So I'm not going to touch on progress, which Mark has already flagged, which is clearly our primary care implementation study to see if we can get pharmacogenetics delivered in clinical practice. But we've got a number of other work packages, and a number of people in the audience leading those. So Vidya, right in the middle, is leading a couple of work packages, one around how patients access their own data and thinking about that. We increasingly, and since COVID, I think, we've seen that people absolutely want more access to their own personal clinical healthcare data. And I was chatting to Ron earlier, and that's something that in the Netherlands people have already. And we've been a little bit resistant to that in the UK and thinking about how we can support that. Catherine Payne is here, who leads the Health Economics programme, which has been focused to some degree around looking at some of the data contextually around the progress study, but also Catherine's been working with Somnath and Tom, who Tom will speak a little bit later about their childhood asthma work with one of her colleagues, Sean Gavin. And then also we're looking at some work around the use of clopidogrel pharmacogenetics, and Vidya will talk a little bit about that. He's working with a number of people in the room, including Vicky Chaplin, around that, but also thinking about clopidogrel pharmacogenetics in the context of coronary artery disease, and there are people in the audience who I know are very interested in that. Emma McGavin unfortunately can't be with us today. Emma is a clinical pharmacologist here in London who's been doing some really fantastic innovative work in this space, but it's got a particular program of work, two programs of work, one that I'll flag where she's been working very closely with the Genes and Health study, which is looking at a number of different genetic factors in the Pakistani and Bangladeshi communities. She's done some pharmacogenetics studies and work in that area, but she's just undertaken a very large survey using a public sort of approach, nationwide approach, which hopefully will be emerging over the next little while, which really talks to what Mark was saying, getting that public and patient voice right at the centre of driving what it is we want to be doing. David Wright, I don't think, has been able to join us today. David's a community pharmacist who is based in Leicester. He's been working very hard on putting together a big community pharmacy programme, which some of you in the audience are involved with, an application into NIHR to look at the implementation of pharmacogenetics in that sort of different setting and complementary setting to GP. And then Munir's here at the front. All of you will know Munir, who's been sort of the driving force of pharmacogenetics in the UK and beyond for a number of years. And one of the hats that Munir's wearing at the moment is very much driving forward a programme of work around cancer with some of his colleagues at the Clatterbridge and beyond. There's sort of 3 new projects around that, but also extending the work that we've been doing on DPYD. That's been introduced into the UK as routine genetic testing for patients starting fluoropyrimidines, which is great, but we know that the genetic variants we test for at the moment don't capture all the diversity around that. And so Munir's been taking a lead on that programme of work. We're going to have a workshop on mental health pharmacogenetics today. Elvira has been doing a lot of work in this space. There's a number of different projects in the space, both hospital and community-based. We know that people often don't respond well to their antidepressants. They have side effects from a whole range of medications, and us trying to create a coherent program of work in that space is going to be really important. And then John and myself have been working, as you know, for a long time on point-of-care pharmacogenetics. It's something that we think has got value in certain clinical scenarios, and one of those is in the neonatal unit, where you can avoid gentamicin-induced hearing loss. We're just officially waiting for the outcome of a new grant, which will be announced in the first week or so of November. And that will hopefully allow us to spread that genetic testing to other centres around the country, so Wales, Scotland, Northern Ireland, and some other centres in England, and provide the evidence that NICE have requested after the early value assessment. So that's a little bit of a very quick update. As I said to you, we're really keen to hear new ideas, and one of the delights of the last few months has been having conversations with some of the people in the room who have come to us with ideas saying, what about doing pharmacogenetics in these different settings? What about in palliative care, in care homes, avoiding drug-induced liver injury? You know, are there things that we can do to progress that work? Is there some aspect that, as a network of excellence, we We don't want to do everyone's project. We don't want to take over people's projects, but we want to provide some support, whether that's in applying for grants, providing some expertise in a particular area. That's something that we're very keen to do. Very keen to understand a little bit more about the power of these population studies. And so there's some really great work going on in Estonia, but using resources like UK Biobank. We've had conversations with our Future Health. So understanding those elements is going to be important. I know there are a number of people in the audience today from industry, very keen to understand some of the perspectives there, what is possible, what the needs are. We're having a talk from Richard Turner this morning, giving his perspective. And that's something that Munir has been linked into, awaiting the outcome of a grant from Innovate, looking at some of the regulatory aspects, which are really complex and need bringing together. So I'm going to stop there. I'm going to let John take the floor and tell you a little bit about where we're up to. Thanks.
Thanks very much, Bill. So what I want to try to do in this 15, 20 minutes or so is outline where we're up to with the Network of Excellence and the Progress Programme, highlight some of the remaining uncertainties and how we think some of the work we're doing can address some of those uncertainties. So anyone who was at the event in March or has seen me present over the past 2 years will have seen this diagram, which talks about how genetic variation can be used to provide insights into personalised medicine. So we know genetic variation is incredibly common. The question is, how do we take knowledge of that variation and use it in clinical practice? So we separate that into a number of artificial steps, understanding that genotype to phenotype correlation, making sure there's technological solutions, and then actually implementing that in clinical practice. And embedded within all of that, as already discussed today, we need to check that's acceptable to clinical and public stakeholders, and to ensure that this intervention, because it can cost a lot of money, is cost effective, working with health economic colleagues. And across that, there are so many questions that need to be answered. There's questions around what genes should we be testing for, what variants should we be testing for, in which clinical context should this intervention be deployed, and to whom? Which technological solutions should we be using? Should we be very targeted testing? Should it be very broad? And from an implementation perspective, how do we test that in reality? How can we collect real-world data to use that in practice? And so many of these questions we're looking at answering as part of the Network of Excellence, but clearly too much to focus on today. And what I tried to do in March was to outline how we've rationalised some of those questions into 3 key areas, which I'm not going to go over in detail again today, but essentially looking at the testing. So which technology should we be using, and does that vary by clinical context? How do we handle that data? How do we make sure it has longitudinal value and is used appropriately? And then how do we embed that in a model of service delivery? And what I want to do is to try to explore how some of our thoughts in these areas have evolved over the past few months, and where we think the key challenges and opportunities are. And probably the most relevant example at the moment, which Vidya is going to be talking about in detail later, is recent guidance from NICE that all patients who've had a stroke or TIA should be offered CYP2C19 genotyping to guide their care. And so that genotype to phenotype relationship has been really well established, and NICE guidance has been put together saying that this should happen. The technology is not really the problem. We can test for these variants quite easily. That's not a challenge, whether it's laboratory, whether it's point of care. The real question is implementation. How do you ensure that data is available to stroke physicians, healthcare professionals in that clinically relevant format and clinically relevant timeframe? How do you make sure that you can deliver those results in a way that can be used at that point in time when it's needed? And that's really complex in a complex healthcare ecosystem where patients move around, laboratory testing may take some time. How do we make that happen? And that implementation piece is something that we've focused an awful lot on. And it's that particular challenge of, yes, we might use laboratory testing. How do we make sure that data moves into that particular point of clinical need at the right time? And that's around laboratory pathways, that's around data, that's around informatics solutions, And that is the biggest challenge in pharmacogenetics. How can we make sure that is used in practice? And when we think about that model of service delivery, it's something that we've tried to expand and develop over these past few months. But it's really important to separate that genetic testing from that model of service delivery. And it's something that I think in the pharmacogenetic literature, we've not done potentially quite as well as we could have done. And so as a thought experiment, what we've tried to do is to say, okay, very broadly, genetic testing can be single gene. That might be single variants in a single gene. It might be sequencing that entire gene, or you can do panel-based testing. And then once you have that data, the question of how you then use that in clinical practice is your model of service delivery. And again, very broadly, you've got reactive approaches, reactive with planned reuse, or preemptive approaches. And you can combine them in multiple different ways, as I'll show you in just a few seconds. But to explain that schematically, what we do at the moment, broadly, so DPYD testing, for example, patient comes into clinic, you think they need a DPYD test, you then arrange the test, it's sent to the laboratory, you get the results, hopefully within 5 days, and then you can use that information to prescribe their chemotherapy or adjust their dose accordingly. That tends to be traditionally how we've delivered genetic testing and how we've delivered pharmacogenetic testing. Reactive with planned reuse is that model where you don't just use it for that single indication, you do the genetic testing, results are returned, but then every time the patient presents thereafter, you can use that information into the future. So what you're doing at that point is you're creating longitudinal value from your pharmacogenetic information. And when you start to think about the ongoing value of that information, which feeds into those health economic assessments, that's potentially where you start to get bang from your buck from your pharmacogenetic testing. And then fully preemptive testing is this model where actually don't wait for the clinical indication. Don't wait for a patient to have a stroke. Don't wait for a patient to present to their GP. You just undertake this testing at a set point in time, embed it within their healthcare records, and then it's available thereafter. And point of care, as Bill said, is another approach which we focused on a lot in Manchester, and we've worked with GeneDrive. There's other technologies out there like Genomatics that can rapidly generate that at the bedside. So you remove the need to undertake pathways where the test is sent to the laboratory. So you remove that issue of turnaround time. And we've done a piece of work in that in NICU, and as Bill said, we're waiting on the outcome of a grant for UK deployment at the moment. So what we've done, this is part of a paper that's in pre-publication at the moment, is in theory, you can combine your testing approach with your models of service delivery in any way that you want. Some of those make more sense than others. And what we do at the moment is that single gene reactive testing that's up in this top right-hand corner over here. But increasingly, healthcare systems around the world are moving towards that kind of lower left quadrant of that table, where you're doing panel-based testing and then you're reusing that data over time. So yes, you might be doing a test to guide clopidogrel therapy, and so you're returning the CYP2C19 result, but at the same time, you deliver lots of other genes, and then you can use that again in the future. And that's where healthcare services, the Netherlands, the US, are really leading on that particular space. And that's what we've focused on as part of the Progress study. But reuse of data adds considerable complexity on both an individual and a population level. So that paradigm, you've done a CYP2C19 test and you're returning that for a particular clinical indication to a particular clinician and one clinical scenario. But as soon as you introduce panel-based testing, you've got multiple genes, multiple variants, and then you're not just returning that to a single healthcare professional, you're returning that to be used by multiple healthcare professionals over a period of time. So you're introducing spatial complexity and temporal complexity. And the informatic solutions that are required to deliver that and the healthcare solutions that are required to deliver that are far more complicated. And you introduce far more complexity, far more challenges, but the opportunities, as we'll come to in a second, are potentially far greater as well. So that's the individual complexity. But when you think about complexity on a population level, I just want to highlight a study that, again, is in pre-publication at the moment at the QJM. We undertook a study implementing pharmacogenetics to improve prescribing, recruited 500 patients at our hospital, and these were unselected patients admitted to an acute medical ward. It was an observational cross-sectional study, and we essentially did pharmacogenetic testing, and we captured their electronic healthcare record data to look at the medicines they had been exposed to on just that single admission. And what we found, as many studies around the world have found, is that the vast majority of people carried a pharmacogenetic variant that was considered a non-wild type result. And as expected, we saw significant differences in variation based on biogeographical background. And then when you compared that to the medicines those individuals had been exposed to, we found that around 50% of patients, again, this is just one single admission, had pharmacogenetic results related to a medicine that they were exposed to during that admission. And had that data been available, remember it was observational, it was non-interventional, just under 1 in 7 individuals would have had a clinically actionable interaction. And the relevance of this is to highlight, again, this is a single admission. This is not looking at longitudinal GP data or even longitudinal admission data within a single hospital, is that if you were to implement this at scale, the potential impact on prescribers would be significant. If you were flagging these in their results, in their electronic healthcare record, if people were actually using every single one of these results to guide prescription, you would have a major impact on how healthcare professionals were prescribing on a day-to-day basis. So we'd need to make sure those solutions were built appropriately, but that adds considerable complexity. It would change the way we were prescribing our most common intervention in healthcare on a routine basis. And so in a resource-constrained system, who do we test? And question is not going to be answered in this slide, but this is a real challenge. As you've seen from that slide I just presented, that's most individuals who potentially would have relevant pharmacogenetic data and are clearly going to be exposed to these medicines. And so there is no clear answer to this. I mean, with single gene testing, the answer is somewhat clearer. You have guidance from NICE, you've got recommendations from the MHRA, and when it's single gene, single clinical scenario like DPYD around the prescription of chemotherapy agents, that makes sense. You test those patients. Same with CYP2C19, ischemic stroke and TIA. You've got clear guidance. But as you start to move towards this panel-based approach, reusing data, those questions around who do we target in the population do become less clear. Lots of people will have their own opinions on how we should focus that. There need to be health economic input into those questions, but they are less straightforward. And these aren't answers to this question that I'm about to give, but they're to maybe stimulate some discussion. And so there have been healthcare services around the world who've looked at an age-based cutoff. So we know people are more likely to receive medicines as they get older, so why don't we test people over age? And what we found from the IPTIP study was that as your age increased, the likelihood that you had a clinically actionable variant would also increase. Now, that's clearly not your genetics changing with age. That's because you're exposed to more medicines over time. So on a very simple level, could you pick an age cutoff where you think on a population level, people are more likely to receive these medicines? But again, this isn't powerfully predictive. The AUC is relatively low here, is very low here, but that's one approach. You could look at comorbidity based when patients are diagnosed with a certain condition, then they're increasingly likely to receive certain medicines. Could that be our cutoff? But then as you start to move towards that real preemptive approach, well, the point is you don't wait for that particular clinical indication and you move towards a more screening type approach. And we know the Generation study has launched in England, and so the question of this data being available, in theory, being available throughout an individual's life becomes more of a reality. There's technical questions around how you access that pharmacogenetic data, how you store it over time, but potentially exploring the idea that it is going to be normal, this data is ubiquitous within patient records is an increasing reality. But this question of who do we test when it comes to panel testing is really important, and I think a yet unanswered question. But the potential benefits, the potential rewards from getting this right could be significant. So we know antidepressants, antiplatelets, opioids, pain relief are incredibly commonly prescribed. They cost a huge amount of money for the healthcare service, not just the medicines budget, but also lost productivity with people unable to work. And so this is the cost of prescribing those medicines, according to the Business Service Authority. So arguably even small improvements, if you could get your service right in the effectiveness or safety of these medicines, could have a major impact on a population level. And clearly that's why there is such enthusiasm around exploring this as a potential opportunity. Now, I want to be quite explicit that what we're doing as part of the progress study in the Network of Excellence is not trying to demonstrate that pharmacogenetic testing is an effective thing to do. So showing that, as has been done in the PREPARE trial that Munir and colleagues were part of, that demonstrated that 30% reduction in ADRs. We're not trying to replicate that. We're not trying to show that again. What we're trying to do as part of the progress program is ask the question, well, if we were to do this, how can we actually make this happen in reality? Is it even feasible to get this data back to healthcare professionals around the healthcare system so it can be used? And so the progress study has really acted as a vehicle to answer some of these key questions around the testing, questions around the data, and questions clearly around the service. And as I've already articulated, what we've moved towards is this approach of reactive with planned reuse using panel-based pharmacogenetic testing on this kind of left-hand quadrant of the screen. And so what are we doing as part of the progress trial? Many of you will be aware of it. The video was mentioned earlier that we had fun creating, and I've taken some screenshots from that because I didn't trust embedding a video into this. But essentially, a patient attends their GP, and if they're considered for one of these index medicines, so certain antidepressants, opioids, PPIs, or statins, they're offered this test to say, well, we could do a pharmacogenetic test that could be used to guide your medical therapy. And then the patient's consented to the study. Sample is sent to the laboratory, PGX testing is performed, and then critically, the data is then passed into something that we've developed called Progress RX and the Geno system, which I'll show you in just a second, and it's returned to the GP. And we're aiming for a turnaround time of less than 10 days, which we're achieving at the moment. But essentially, the results are then surfaced to the GP within a separate portal, which is this Geno system, or guidance as of last week is now available within the electronic healthcare record, which is a major advancement from our perspective. The prescription is then issued or amended as appropriate, or the patient's told you're on the appropriate medicine, or we can prescribe your medicine as we initially discussed. And then we're then collecting data from the electronic healthcare record system as our outcome measures to understand, was that data used, how was that data returned, who accessed that data. And as I said, our outcomes are explicitly, we have not powered this study to answer questions on that clinical utility. We have done this study to look at the performance of the pathway, so turnaround time, results generation, and then phase 2 really looks at that adherence to guidance. So are healthcare professionals changing that prescription based on the guidance that we provide, and are patients remaining on that medicine over a period of time? And so, as you can imagine, this is in primary care, and there is complexity in doing a type of pharmacogenetic test in this setting. We've got 14 sites live in the northwest of England at the moment, and then we have 13 sites in various stages of setup across England. As you can see down at the bottom there, our first phase 2 site went live, Abbywell practice, last week. And so this is the first practice, as we'll come to in a second, that is having data directly flagged, pharmacogenetic guidance directly flagged within their electronic healthcare record. So it's been a major milestone for us. And so phase 1 complete, and so we've had approximately 400 patients recruited from the northwest of England, and you can see some timelines here, and we're returning results in approximately 8 days. So we're seeing those results returned in what we deem to be within the study, that kind of clinically relevant time frame. But you can see where that timeline is broken up. So review to recruitment, so the patient seen by the GP to actually being recruited by the research team takes around a day and a half. Sample transit, that can take some time, and that's not about the postal system or the van driving to the hospital. That's around the patient who will be at home, potentially, taking their sample back to the GP. It might take them a few days to remember to do that. And then receipt to DNA extraction, and then extraction to results. So again, the actual testing, we've developed a process which is very, very quick. And what we've seen, again, is that looking at these 4 key genes, so CYP2C19, 2D6, 2C9, and SLCO1B1, the vast majority of patients had a clinically relevant variation in one of those genes. Around 10% of patients had what we'd consider to be a red flag result, where there was guidance that an alternative agent should be used, and around 30% had an orange flag, which was an increased risk of side effects, a warning about a dose change or advice on titration change. And what we've seen is that around 90% of that guidance that has been returned at this early stage has been used by healthcare professionals. We find that if the prescription hasn't been issued already, so GPs have the flexibility to issue the prescription and then amend once they've got the results, or they can just wait for the results to be available. If they wait for the results to be available, the guidance is almost always followed because they have that information, they can issue the prescription based on the genotype data. If they've already issued the prescription, we then see a reduction in adherence to those guidelines, which isn't surprising, but it speaks to that question of the value of having that data already available within the patient's electronic healthcare records. And then thinking about phase 2, so our aim is to recruit 1,200 patients from across England, and to address some of these challenges that I'll just go back to in this pathway. So we want to make this as rapid as possible, because we know that every day that we take longer, the likelihood that that's of value to that GP reduces. And so we've introduced an asynchronous recruiting model. So patients are given a pack when they see their GP, or they can come pick it up from their GP. And in there is everything, in theory, that they need to be recruited to the study. They can log on to an online portal, they can consent to the study themselves, they can watch a video that we've generated, which I'll show you some screenshots from in just a second. They complete a saliva kit, and then, as you can see here, they consent online, complete the saliva kit, and then they go to a post box and just put it in any post box. So they don't need to take it back to their GP. And we've seen a really significant improvement in that transit time because of that, because they can just go to their local post box. They don't have to worry about taking it to the GP, and they can do that at any time. And that's been really powerful. And then the big thing for us as part of phase 2 is that interoperable data solution, which many of you will have seen us speak about before, but I'm happy to provide an update on. So we know that as part of phase 1, the way we're returning results is via this system called Geno. Very simply, you log in, you search for your patient via their NHS number, and then what you can see here, if this patient has been recruited to the study because they've been prescribed citalopram, you see results related to that particular medicine there. You can search for the medicine. So if you wanted to look at atorvastatin, this patient has an SLCO1B1 normal function, and so you should give that medicine appropriately. What we're moving to as part of phase 2, which has just started this week, and we've had very productive relationship with our colleagues at First Data Bank designing this solution with clinical architecture, is that we've created a solution which is agnostic of your genotyping platform and agnostic of your CDS, your EHR provider. And the way we've done that is to move the data into this cloud-based system called ProgressRx and utilize data standards. And so what that means is that when we will upload the data from the laboratory system, it's moved into this consistent data standard, and then when the healthcare professional goes to prescribe a relevant medicine, so let's say they go prescribe codeine, there's a handshake between the local EHR CDS provider and ProgressRx, and any relevant guidance is then flagged within their healthcare record system, and I'll show you an example of that in just a second. The data standards piece is absolutely critical. So if you want to make a solution that is truly interoperable, and Vidaire has led on this with colleagues at Fresh Air, we have just released a data standard model using open EHR archetype. So that's available there, and there'll be a paper coming out on that relatively soon. But essentially, in practice, what that looks like is something like this. And again, this is a mock-up at the moment, but this is being used at Abbywell right now. Essentially, this patient's been prescribed codeine. You can see a high severity warning. Sorry, it doesn't project particularly well, but they're a poor metabolizer for CYP2D6, so that agent should not be used. And all of the work that we've done, whether it's through surveys, focus groups, discrete choice experiments, has demonstrated that this is one of the key drivers of uptake for clinicians. If you ask people to go out to a separate system, or even worse, you give them a PDF, they are just not going to use that again over time. If we want pharmacogenetics, panel-based pharmacogenetics that is going to be used longitudinally over time, we have to develop these interoperable solutions in the NHS. Otherwise, it will just not be used in practice at scale. And so thinking to the future, again, we're agnostic of the inputs on this end. And I think there's a real opportunity to look at, we spoke about the generation study before, the idea of trying to extract pharmacogenetic data from NGS is really exciting, and working with colleagues at Genomics England, I think there's huge opportunities there. So we're not restricted to traditional panel-based pharmacogenetic testing, but also all of the genetic data that is available. And then what's going to be really important is thinking about how we continue to show the value of this intervention on a population level, and to do that, capturing routinely collected healthcare data, utilising tools like the Secure Data Environment or the FTP will be really important. And what you can do, not only just show the value of your intervention, but also you can start to develop insights into new gene-drug associations. And then we've talked about putting data into the Progress RX solution, but there's no reason in a controlled way you can extract data from that as well. And so if you've got the NHS app or a third-party application, patients want to view their results. We know that from all the work they've done, and extracting that data in a controlled, consistent way is really powerful, really important. So thank you very much. I'm happy to answer any questions. Yeah, happy to talk throughout the day.
That's good. Yeah, so we do have time for a couple of questions. Thanks so much, John. I mean, it's really great advances over the last few weeks, particularly with any project like this. There are lots of moving parts, things get in the way, there's some complexity and challenges, but the fact that we've got to a point where we've got our first practice up and running, that the data is being surfaced in this way is really fantastic, and we're really excited about opening up sites in the West Midlands, Cambridge and some other centres around the country. And the plan is to go to the 6 sort of other GMSA regions in England before then we take a little bit of stock and see, right, how many centres do we have? Are they all operational? Do we need others to get to help us to get to a point where we can get the recruitment that we need? So we're estimating that it's going to be sort of towards this time next year that we'd be sort of closing recruitment for this particular programme. But then, of course, we've got to think, what's next? How do you roll that out? How do you make this sort of business as usual, rather than this just being, oh, that was an interesting study, let's everyone forget about it. That's, I think, a really big challenge for us. Questions? Yes, here, and then there, and then we'll round up. Thank you.
The orange and red flag percentages, are those percentages reasonably similarly distributed across the different drug types?
No, they weren't. So with regard to recruitment, so we don't have gating like the Prepare trial did. So essentially, we will continue recruiting to the different drug classes, irrespective of the numbers we're recruiting through. But our main drug classes, as you'd expect, are antidepressants and statins. The way we've classified the red, orange, green is that for the antidepressants, we see a lot more of those orange and red flags. Yeah, but there is that spread.
It's a good answer for a psychiatrist.
The yes question there, and then we'll. Yes, so it's a really good point. Jess, do you want to say something about that? No? Okay. So Jess has been working with a number of colleagues, with Emma and Emma Groves, and then linking with Vicky Chaplin and colleagues to work out about how we sort of deliver an education and training programme in this space, because clearly that's going to be really important, working out who needs to know what and where. And of course, this can't be delivered by just a small number of people. This needs to be delivered by profession and getting primary care involved, and both at a GP level and a pharmacist level is going to be absolutely key. So hopefully we'll know a little bit more soon and be able to sort of formalise that and share that. And that, I think, hopefully will be one of the topics that we'll be able to give a little bit more airtime at the next meeting. But there's been a lot of work in the background around that, and I think there'll be some sort of comms going out about what we can do to sort of develop some of those resources. We absolutely see it as fundamental to delivering this, but it's sort of at a slightly earlier stage, if that's okay. And final question there. Yeah, so that's an area that I'm probably not as close to, but there are people who are in our team that are close to that. So Vicky has been working with Scott Watson, Vidya, a number of people thinking about, we want to create a solution within our project and our program that works and is effective, but we are very cognizant of that this is, you know, a much bigger piece of work that's going on. And we don't want to create something that doesn't have some longevity or can't be useful for that long-term perspective. But what we've described, as far as we sort of are thinking about it in the context of progress, is a system that should, in theory, be able to work with surfacing any genetic information. So now lots of people are talking about polygenic risk scores and how do you use those. And, you know, if you gave a GP a polygenic risk score, their head's going to be scrambled. You know, you need to give them something that they can use and guides and gives advice. So the shifting away from a number or a result that is quite complex to interpret is something that I think this is starting to help guide some of that conversation. So when we deliver those broader solutions, that they're taking some of those things into consideration. So that's going to be a huge piece of work, and there are lots of people that know far more about it, that understand the complexity of it, but hopefully our work can contribute to that in some way. Right, we're going to move on. There's going to be lots of opportunity to talk to people about what's going on in progress. We're happy to do that.